Hello and welcome to this educational presentation from Professor Mohammadi's Educational Archives. Evaluating weakness in children can be challenging because young children may not describe their symptoms clearly, and examination findings can vary with age, cooperation, and developmental level. A careful and structured assessment helps us distinguish true muscle weakness from other causes of reduced movement, prevents misdiagnoses, and avoids unnecessary investigations or delays in treatment. By the end of this presentation, we should be able to distinguish hypotonia from true muscle weakness, recognize upper and lower motor neuron patterns, identify the distribution of weakness and associated clinical features, and detect red flags that require urgent evaluation. Most importantly, we will use a systematic clinical approach that reduces common diagnostic errors and helps guide appropriate investigations. Hypotonia and weakness are related concepts, but they are not interchangeable. Hypotonia refers to reduced resistance to passive movement. A hypotonic child may appear floppy, particularly at rest, but muscle strength may still be relatively preserved. Deep tendon reflexes may be diminished, normal, or occasionally increased, depending on the underlying cause. True weakness means reduced ability to generate muscle force. The child may have difficulty moving against gravity, tire easily, struggle with functional activities, or demonstrate measurable loss of power. The key clinical message is that a floppy child is not necessarily a weak child. Tone and strength must therefore be assessed separately. A systematic evaluation begins with history and observation. We should determine whether the problem was present from birth or developed later, whether it is static or progressive, and whether developmental milestones have been delayed or lost. Family history, medication exposure, recent infection, and associated systemic symptoms may also provide important clues. During examination, tone and power should be assessed in more than one position. Reflexes and plantar responses should be examined systematically, and the child's gait should be observed directly whenever possible. We should also determine whether weakness is proximal or distal, symmetric or asymmetric, and whether respiratory or bulbar muscles are involved. Because findings can evolve, repeated examination is often more informative than a single assessment. Upper motor neuron involvement is suggested by hyperreflexia, clonus, and extensor plantar response and spasticity. Hyperreflexia refers to exaggerated deep tendon reflexes. Clonus consists of rhythmic involuntary contractions triggered by sudden muscle stretch. Spasticity is a velocity-dependent increase in resistance during passive movement. An extensor plantar response, particularly when it is developmentally inappropriate, may indicate corticospinal tract dysfunction. These findings can be subtle in children and may be missed when the examination is rushed or incomplete. Careful comparison between both sides and attention to age-appropriate responses are therefore essential. Lower motor neuron disorders usually produce a different pattern. Typical findings include hypotonia or flaccidity, reduced or absent deep tendon reflexes, muscle wasting, and fasciculations. Weakness may be prominent, and the child may have difficulty maintaining posture or performing age-appropriate motor activities. This pattern contrasts with the increased tone and brisk reflexes generally associated with upper motor neuron disease. Recognizing the difference between upper and lower motor neuron signs is one of the most important steps in neurological localization. The distribution of weakness can provide valuable diagnostic information. Proximal weakness affects muscles around the shoulders and hips. These children may have difficulty climbing stairs, rising from the floor, lifting their arms, or maintaining an upright posture. Distal weakness affects the hands and feet and may cause foot drop, frequent tripping, difficulty with fine motor tasks, or problems walking on the heels. We should also determine whether weakness is symmetric or asymmetric and whether axial muscles are involved. Associated sensory loss, coordination difficulty, pain, speech disturbance, swallowing problems, or bladder dysfunction may further help localize the lesion and narrow the differential diagnosis. There are 5 particularly important diagnostic pitfalls. The first is confusing hypotonia with true weakness. The The second is missing subtle upper motor neuron signs, especially mild hyperreflexia or an abnormal plantar response. The third is ignoring the Gower sign, which may indicate proximal muscle weakness. The fourth is assuming that all toe walking is benign when spasticity, dystonia, contracture, or neuromuscular disease may be present. The fifth, and potentially most dangerous, is failing to recognize respiratory muscle weakness. Avoiding these pitfalls requires direct observation, careful examination, and attention to functional abilities rather than relying only on isolated muscle testing. Several findings should increase our concern for clinically significant weakness. These include reduced strength against gravity, rapid fatigue, poor endurance, difficulty running or climbing stairs, and difficulty rising from the floor. Loss of muscle bulk, declining mobilities, or findings that are inconsistent with the child's developmental age should also prompt further assessment. Functional observation is particularly useful in young children who may not cooperate with formal manual muscle testing. Watching the child play, reach, stand, walk, and climb may reveal abnormalities that are otherwise overlooked. Several practical steps can reduce diagnostic errors. Tone should be examined in different positions, including supine, prone, sitting, standing, and in infants during vertical or horizontal suspension. Deep tendon reflexes should be assessed systematically at multiple levels. The child should be observed walking, running, turning, climbing steps, and rising from the floor. Respiratory rate, work of breathing, cough strength, and use of accessory muscles should also be assessed. Finally, progression should be documented over time. Before ordering extensive tests, the clinician should consider the major etiologic categories, including myopathy, neuropathy, anterior horn cell disease, central nervous system disorders, neuromuscular junction disorders, and metabolic or toxic causes. Respiratory and bulbar assessment should be included in the examination of every child with suspected weakness. Respiratory muscle involvement may present with rapid shallow breathing, weak cough, reduced chest expansion, use of accessory muscles, orthopnea, morning headaches, or recurrent respiratory infections. Bulbar dysfunction may cause difficulty swallowing, choking, excessive secretions, nasal speech, dysarthria, or a weak voice. These findings may initially be subtle, but they can indicate a developing neuromuscular emergency. Early recognition allows timely respiratory support, airway protection, and specialist involvement. Several red flags require urgent evaluation. These include sudden weakness, rapidly progressive weakness, breathing difficulty, a weak or ineffective cough, swallowing impairment, and a weak or changing voice. Bulbar symptoms, rapid muscle wasting, fasciculations, frequent unexplained falls, loss of walking ability, or any acute neurological deterioration should also be taken seriously. When respiratory or bulbar function is threatened, diagnostic evaluation and supportive management must proceed urgently and in parallel. The differential diagnosis is most effectively organized using a localization-first approach. Myopathies often produce symmetric proximal weakness with sensation usually preserved. Neuropathies commonly cause distal weakness, reduced reflexes, and sometimes sensory abnormalities. Anterior horn cell disorders may produce weakness, hypotonia, fasciculations, and arflexia without sensory loss. Central nervous system disorders are more likely to produce spasticity, hyperreflexia, or additional cortical and developmental findings. Neuromuscular junction disorders often cause fluctuating or fatigable weakness, while metabolic and toxic disorders may produce episodic, multisystem, or exposure-related patterns. Clinical localization should guide the choice of investigations rather than allowing tests to replace examination. Consider a 6-year-old child who has difficulty climbing stairs and rising from the floor. Direct observation reveals a waddling gait and a positive Gower sign. Examination shows symmetric proximal weakness, reduced tendon reflexes, and no sensory deficit. Respiratory screening does not reveal accessory muscle use. This pattern suggests a motor unit disorder, particularly a myopathy or an anterior horn cell disorder. Serum creatine kinase can help identify muscle injury, while electromyography and nerve conduction studies may further clarify localization. The child also requires specialist referral and continued respiratory surveillance, even when the initial respiratory examination appears reassuring. The key lessons are straightforward, but clinically important. Take a careful history and perform a complete neurological examination. Observe the child directly rather than relying only on parental descriptions or formal strength testing. Assess gait, functional activities, reflexes, tone, respiratory function, and bulbar function. Localize the problem before selecting investigations and arrange close follow-up when the diagnosis remains uncertain. In pediatric neurology, repeated examination may reveal progression or emerging signs that were not apparent during the first visit. The central clinical pearl is this: when in doubt, re-examine, re-evaluate, and seek expert advice. Weakness in children may be subtle, evolving, or difficult to separate from developmental variation, poor cooperation, fatigue, pain, or hypotonia. A careful history and complete neurological examination remain the foundation of diagnosis. Investigations should support clinical reasoning, not replace it. Thank you for your attention. This presentation has been brought to you from Professor Mohammadi's Educational Archives. I hope this review supports a more systematic, confident, and clinically focused approach to evaluating weakness in children.